بسم الله الرحمن الرحيم. This talk is about proteinuria and nephrotic syndrome. I am D.رشا Samir, lecturer of nephrology, and this will be my agenda. Introduction: proteinuria, when does it develop? What's meant by nephrotic syndrome? What are the causes and pathological types? How to diagnose nephrotic syndrome and how to manage. Every one of us knows the kidney is formed of two parts, the outer part, which is the cortex, inner part, which is the medulla, and taking a sector from the kidney tissue and magnifying it, we will find that there are globular structures, which are the filtering units of the kidney, the glomeruli. These globular structures is connected to yellow tubes. These are the renal tubules, and there is a rich vascular network of arteries and veins, branches surrounding these nephrons and supplying or providing the blood supply of the kidney. So the nephron depths between the cortex and medulla. Parts of the nephrons are located in the cortex, and other parts like lobe of Henle are located in the medulla. The nephron is a functional unit of the kidney, and each kidney contains about 1 million nephrons. So among the parts of the nephron, the glomerulus. This filtering unit is the accused part to be responsible for significant proteinuria. Having a further look at these glomerulus and further magnifying, the glomeruli receive blood supply via the afferent arteriole. This afferent arteriole brings blood to the glomeruli loaded with waste, which are these yellow globules. And after this blood reaches the glomeruli and it filters it from its waste, it returns back to the circulation via the efferent arteriole. Here we can see that the blood coming to the glomerulus is loaded with waste, which are the yellow globules, and the proteins, which are the blue globules. And as we can see, normally and under normal conditions, the glomeruli filter the waste and not filter the protein, so protein returns back to the circulation through the efferent arteriole. This is how the glomeruli looks in a cut section. So this globular structure is a glomerulus. There is afferent and efferent arteriole, and there is filtrate coming to reach the renal tubules, and surrounding there are cut sections of renal tubules surrounding these glomerulus. So one glomerulus contains number of capillaries. So this one of these capillaries, we can see there is a capillary where is the lumen, and the lumen contains red blood cells, and there is a basement membrane surrounding this lumen, which is this one appears in green. And on the inner side of the membrane, there is endothelial cell, this cell in yellow, with fenestrated endothelium lining the basement membrane, and there are other cells on the outer surface of the basement membrane, which is called the podocyte, and which send food processes to cover the outer surface of the basement membrane. These capillaries are connected via connective tissue, which appears below in this image. This is called the mesengium, and the cells it's containing are called mesangial cells. So magnifying one of these capillaries, we can find that there is a capillary lumen, and there is a basement membrane in green, and there is the endothelial cell on the inner side of the membrane sending fenestrated endothelium, and there is the podocyte, on the outer surface of the basement membrane, sending food processes covering the whole surface of the basement membrane. And this is a mesenterium connecting the one capillary to another, and all these layers are considered to form the glomerular filtration barrier. These are the layers of glomerular filtration barrier. The basement membrane, the lining endothelium, and the outer podocytes and food process. All these three layers act as protective layers against escape of protein or albumin particles, which are located inside the capillary lumen, to escape into the urine through filtrate. And this is how the basement membrane looks by electron microscopy. So besides the lining endothelium and beside the food processes located on the outer side, there is a trilaminar structure or trilaminar membrane, which adds to the protective value of this glomerular filtration barrier. These golden cells are the podocytes, and these podocytes send the food processes that coalesce together to cover the whole outer surface of the basement membrane. Look at this. This is a true image taken by electron microscopy. It shows the podocyte and shows its food processes, which send further and further branches covering the whole surface of the glomerular basement membrane. And this is how the capillary lumen looks by electron microscopy also. The layers of basement membrane, food processes of the podocyte. This is the endothelial cell, and this is the mesenterium connecting one capillary to another. Through these layers, the urine passes to the renal tubules, and the protein is kept inside the lumen and back to the circulation after filtration. So if these all protective layers are present, is it normal to have proteinuria? And if not, when does proteinuria develop? Normally, the average adult excretes a daily amount of protein which shouldn't exceed 150 mg per day. And this is the composition of the daily protein excretion. We can see that 15% of this daily protein excretion is albumin, and the remaining 85% is composed of different proteins, including tubular lining, horse fat proteins, hormones and enzymes, mucopolysaccharides and immunoglobulins. The normal daily albumin excretion shouldn't exceed 30 mg per day. So, proteinuria is considered when the total daily protein excretion is more than 150 mg per day, and albuminuria is considered when the daily albumin excretion is more than 30 mg per day. And according to these levels, albuminuria is further classified into A1, A2, or A3. A1 is considered normal with albumin excretion rate less than 30 mg per 24 hours. A2 is considered moderate with albumin excretion rate between 30 to 300, and S3 is severely increased albuminuria with albumin excretion rate exceeding 300 mg per day. The more severe the grade of proteinuria, the higher risk of poor renal survival. So it shows that when albuminuria is more severe in A2 and A3, the renal outcome will be worse, or the renal survival will be worse. Proteinuria is classified according to its origin. Is it glomerular proteinuria? Or is it tubular proteinuria? Or is it overflow proteinuria? Tubular proteinuria refers to failure of the tubules to reabsorb low molecular weight proteins, not albumin. And so, it is not detected on dipstick because dipstick usually detects albumin only. In overflow proteinuria, there is excess production of low molecular weight proteins, and this exceeds the reabsorptive capacity of the kidney. By this, large quantities of protein escape in urine and cause heavy proteinuria, but these proteins also are not albumin in nature, but low molecular weight proteins like immunoglobulin light chain, and this condition happens in case of amyloidosis and multiple myeloma, and it is also negative by dipstick because there is no albumin. And glomerular proteinuria is the most significant one, which is either microalbuminuria, selective or non-selective proteinuria. So, starting from these two kidneys, further magnifying into cortex and medulla, and getting a core which is contained the nephron, and even zooming in to get this glomerulus and its podocyte, the glomeruli, and the gaps between podocytes are accused to be responsible for proteinuria. For this, the kidneys are considered to be the site of proteinuria. But not every proteinuria is due to renal disease. Proteinuria can be due to or cannot be due to renal disease. So among renal causes, glomerulonephritis, and some of other diseases that can cause secondary glomerulonephritis also. And we have non-renal disease like fever, burn, heart failure, severe hypertension, severe exertion. All these can be causes of proteinuria. Proteinuria varies in amount and can be transient and persistent. And among the causes of transient proteinuria, exposure to cold, vigorous exercise, febrile illness, heart failure. Accordingly, as not every case of proteinuria is due to renal disease, so we will go through this approach according to the dipstick results. Dipstick can be falsely positive, and all what we have to do is to recheck. If dipstick is +1 or +2, we have to repeat 2 to 3 times in the next month. If it is transient, just reassure. If it is persistent, we have to quantify proteinuria. If dipstick is +3 or +4 from the start, we also have to quantify. Proteinuria less than 2 grams can be extra or non-glomerular hematuria, but proteinuria more than 2 grams usually of glomerular origin and necessitates nephrological referral. When urinary total protein exceeds 3.5 grams per day, this is considered the nephrotic range proteinuria and also refers to affection of the glomeruli. If the nephrotic range proteinuria exceeds 3.5 grams per day, does it mean that every patient with proteinuria exceeding 3.5 grams per day equals nephrotic syndrome? Here we have to know what is meant by nephrotic syndrome. When the glomeruli are affected by a certain disease, various clinical presentations can result. The patient can be asymptomatic and present with nephrotic syndrome, and among these presentations, here comes the nephrotic syndrome. So nephrotic syndrome is one of the clinical presentations of glomerulonephritis. Nephrotic syndrome is a tetrad formed of nephrotic range proteinuria, which is the hallmark of the disease. This nephrotic range proteinuria, which is principally consisting of albumin, will lead to loss of albumin in urine, and so decrease the level of albumin in blood, and this will result in hypoalbuminemia. And because albumin is the main drive for plasma oncotic pressure, when albumin is lost, when there is hypoalbuminemia, the plasma oncotic pressure will fall, and by this, the fluid escapes from inside the blood vessel to outside through osmosis, and the edema will develop due to accumulation of fluid in the interstitium, and there is accompanying hyperlipidemia and lipiduria due to calming mechanism. When kidney disease develops and there is proteinuria, as we said, serum albumin will fall, and this will lead to decrease in the plasma oncotic pressure. Here, the fluid will shift from the intravascular to the interstitial fluid, and thereby there will be increased interstitial volume or edema. So as we can see, the fluid will escape from inside the intravascular compartment, passing into the interstitial compartment, and the body will try to compensate, because escape of fluid from the intravascular compartment will lead to the state of partial ischemia and maybe renal hypoperfusion. For this, the decreased plasma volume will lead to consequences of a compensatory mechanism, including activation of the renin-angiotensin-aldosterone system and hyperaldosteronism with salt and water retention, which will try to compensate for the intravascular volume depletion and restoration of blood and the plasma volume, and trying to have normal blood pressure. So, activation of the renin-angiotensin-aldosterone system with excessive salt and water retention. However, it can succeed to restore the blood volume and restore a normal blood pressure, but at the same time, it will lead to increase the interstitial. Regarding hyperlipidemia and lipiduria, what happens in nephrotic syndrome is that as a compensation for the urinary losses of protein, the liver increases its hepatic synthesis of lipoproteins including VLDL, IDL, and LDL, which will lead to hyperlipidemia and other metabolic consequences. Another important complication is the tendency for thrombosis or hypercoagulable state. In this condition, besides loss of natural anti-clotting factors in the urine, like antithrombin 3, protein C, and protein S, there is increased hepatic synthesis of procoagulant or clotting factors like fibrinogen factor 5, factor 7, and so on. All this lead to increased liability for thrombosis, whether arterial thrombosis or venous thrombosis. Another important complication which happens as a consequence of nephrotic syndrome is AKI and hypertension. And having a back look to this diagram again, we find that when there is shift of the intravascular fluid from the intravascular to interstitial, this will lead to decreased plasma volume. And when there is decreased plasma volume, there will be renal hypoperfusion. And this explains why AKI, acute kidney injury, can develop as a consequence of nephrotic syndrome. And at the same time, there is renin-angiotensin-aldosterone system activation and salt and water retention, and this will lead to another complication, which is hypertension. These are the complications of nephrotic syndrome: hypertension, acute kidney injury due to renal hypoperfusion, increased liability for infection due to losses of immunoglobulins in urine, which are protein in nature, malnutrition with nutritive losses in urine, and also vitamin D deficiency. Those patients are liable for anemia due to transferrin losses, and especially there will be iron deficiency anemia, and hypothyroidism also can result due to loss of thyroxine binding globulins in urine. What are the causes of nephrotic syndrome? Nephrotic syndrome can happen due to primary affection of the glomeruli. And at the same time, there are many secondary causes of nephrotic syndrome. These secondary causes include infections like hepatitis B, hepatitis C, HIV, syphilis, and malaria. Can occur due to disease or condition, autoimmune disease like systemic lupus erythematosus, amyloidosis, lymphoma, and Henoch-Schönlein purpura, and nephrotic syndrome also can result due to use of medication or drugs. The commonest are non-steroidal anti-inflammatory drugs, gold and penicillamine, which were used for treatment of rheumatoid arthritis, addictive drugs like the heroin, and lithium, which is used as antipsychotic medication. What are the pathological types of nephrotic syndrome? Nephrotic syndrome can be further classified according to the pathogenesis. If there is podocytopathy, like minimal change and focal segmental glomerulosclerosis, in this condition the primary pathology is involving the glomeruli. Or if there is immune complex deposits, and this is what happens in case of membranous and membranoproliferative glomerulonephritis, and in this condition there is deposition of immune complex, or by another way, antigen-antibody complex, which lead to initiation of inflammatory response, inflammatory cascade, and cause injury or damage to the glomerular basement membrane. At the same time, other substances like in diabetes and amyloidosis, deposition of abnormal protein or presence of inflammatory process can lead to nephrotic syndrome. So here the three main mechanisms: podocytopathy, immune complex deposit, and other substance deposit like in diabetes and amyloidosis. These are the common glomerular pathologies causing clinically nephrotic syndrome. So, clinically dealing with the patient, we will see a clinical diagnosis, which is either nephrotic syndrome, nephritic syndrome, or combination between both, and we will show pathological diagnosis like these diagnoses reported here: minimal change, focal segmental glomerulosclerosis, membranous nephropathy, and we have at the end amyloid disease, diabetic nephropathy. All these complications can clinically present by nephrotic syndrome added to the membranoproliferative GN. How to diagnose nephrotic syndrome? First, starting by laboratory parameters. Diagnosis of nephrotic syndrome should include first diagnosing the items out the tetrad of nephrotic syndrome, ruling out complications, and after that, first step, the second step will be searching for the cause. What is the cause for this nephrotic syndrome? To diagnose nephrotic syndrome, we have to do urine analysis and look if there is proteinuria or not. If there is proteinuria, we have to make sure that this proteinuria is of nephrotic range proteinuria exceeding 3.5 gram per day, and we should find hypoalbuminemia and also hyperlipidemia. All these are components of nephrotic syndrome. Ruling out complications means that we should do kidney function test, urea and creatinine, to rule out presence of AKI, electrolytes, CBC to exclude anemia, prothrombin time, ABTT, and the coagulation profile. And after doing these initial investigations, here come the steps for searching for the cause. Is it primary or is it secondary to virus? So here we have to do the viral antigen, hepatitis B surface antigen, or hepatitis C virus antibody, to exclude if there is any autoimmune disease like CLE. So we can do some autoantibodies like anti-double strand DNA and measuring the complement level C3 and C4. We can also measure the anti-streptolysin O-titer to rule out other infections, and doing some radiologic investigations like X-ray and abdominal ultrasound. It's crucial to differentiate between nephrotic and the nephritic syndrome. In nephrotic syndrome, we have usually insidious onset, while it is appear in nephrotic syndrome, the edema is too much marked in nephrotic compared to nephritic. The blood pressure is normal in nephrotic syndrome, and if hypertension develops in nephrotic syndrome, it is a complication, not a part of the cardinal clinical features, while blood pressure is always or usually raised in nephrotic syndrome. Proteinuria is more profound in case of nephrotic. Hematuria more profound in nephritic. And nephrotic syndrome usually reveals red blood cell counts and with a normal serum albumin compared to nephrotic syndrome where there is hypoalbuminemia. Protein assessment in nephrotic syndrome includes qualitative and quantitative protein assessment. So regarding the commonest method for testing for qualitative protein assessment is a dipstick testing. This dipstick testing has limited sensitivity for non-albumin protein, so it always check only for albumin, and therefore is falsely negative in presence of other causes of proteinuria as mentioned before in tubular proteinuria or overflow proteinuria. And also the reaction of dipstick depends upon the concentration of albumin. So testing diluted urine or large volume urine underestimates the degree of albuminuria. And similarly, testing highly concentrated urine may overestimate the degree of albuminuria. These are the normal ranges for proteinuria by dipstick. So +1 refers to protein excretion of about 30 to 100 mg per deciliter. +2, 100 to 300. +3, 300 to 1000. And +4, proteinuria exceeding 1 gram. And this usually proteinuria of glomerular origin. After the qualitative assessment of protein, here comes the role of quantitative protein assessment. We have to quantify protein to see if it is nephrotic range proteinuria or not. As we mentioned before, nephrotic range proteinuria is considered when the daily protein excretion more than 3.5 gram per day. So we have to quantify the total daily protein excretion. We have two methods. The first method is a 24-hour urinary protein collection, and this is a gold standard method, where we collect protein for 24 hours and calculate the total amount of excreted protein. But this method, however, being the gold standard, seems to be impractical, with some errors of collection. So, another more practical method is to do protein creatinine ratio or albumin creatinine ratio. In this condition, we take a spot sample of urine and measure the amount of protein in relation to the amount of creatinine, or the amount of albumin in relation to the amount of creatinine. And these are the normal reference range according to albumin creatinine ratio and the protein creatinine ratio. Kidney biopsy is a gold standard method to diagnose the pathology of the kidney, or to determine the pathological type causing clinically nephrotic syndrome. Doing a kidney biopsy, we have to check by three methods of assessment: light microscopy, immunofluorescence, and electron microscopy. The three items of assessment help to reach more precise diagnosis. Before I go through the pathological types of nephrotic syndrome, I'd like to remind you about the histology of the glomeruli once again. Here we have a number of glomerular capillaries, and these capillaries are lined by basement membrane, and there is a type of cell, which is the endothelial cell, which are located inside the lumen of the glomerular capillaries. This is the first one. These capillaries are held together by the mesangium, and the cells it contains are the mesangial cells. So this is the second type of cells. The third type are the podocytes, which are the cells that are located on the outer surface of the basement membrane, and they are the cells that send food processes along the outer surface of the basement membrane. And the fourth type of cell are the parietal epithelial cells. These are the cells lining the Bowman's capsule. So, we have certain structures inside the glomerulus and principally 4 types of cells, and according to affection of these structures, the pathology will result, and clinically it will determine certain clinical presentation. What are the pathologies that cause nephrotic syndrome? Again, either podocytopathies, as it happens in minimally changed disease, focal segmental glomerulosclerosis, and I will discuss it. Immune complex deposit, as it happens in membranous, membranoproliferative GM, and other deposits in diabetes and amyloidosis. Starting by podocytopathies. In minimally changed nephrotic syndrome, we can see capillaries, and these capillaries seem to be normal. Thin basement membrane. Inside the lumen we have endothelial cell. We have mesangial cells connecting the capillaries together, and on the outer surface of the capillary we can see a nucleus for podocyte. So, by doing light microscopy, it seems as a normal glomeruli. Actually, in case of minimally changed, or when this disease is termed as minimally changed disease, the only available method of assessment was light microscopy. So when they did light microscopy, found normal glomeruli, and at the same time patient clinically presenting with nephrotic syndrome. Accordingly, they termed this disease as minimal change disease, a significant clinical disease, but with minimal pathological changes. But this picture changed when the electron microscopy used in clinical practice. Because when clinical electron microscopy used, here we can see profound difference between both pictures. Comparing the normal versus the glomeruli of minimally changed disease. Here in normal, we can see the full processes of podocyte on the outer surface of the basement membrane and are discrete, but in case of minimally changed disease, we see these full processes fused, and this fusion will result in interruption of the basement membrane at other sites, allowing escape of protein and the proteinuria. So this is regular minimally changed disease. What about focal segmental glomerulosclerosis? First, to understand the term, glomerulosclerosis refers to fibrosis in the glomerulus. And having a look at these glomerulus compared to the previous one, we can see there is a sector, part of the capillaries inside the glomeruli, which is involved by certain pathology. This is sclerosis, or we can consider it fibrosis of these glomerular capillaries. Here we have to understand what is meant by focal and segmental. When we look at the glomeruli under the microscopy on a slide, pathological slide, we will see a number of glomeruli. If the pathology is involving all the glomeruli or more than 50% of the glomeruli, this is termed diffuse. And if the pathology is involving less than 50% of the glomeruli, this is termed focal. What about segmental? If the pathology is involving only sector inside one glomerulus, this is segmental, only segment or only sector. But if the whole one glomerulus involved by the pathology, this is global. And usually, mild cases start by focal and segmental, and with time, this will change into diffuse and global. So look at this. The first one, segmental. There is affection of one segment of the glomerulus. A sector or segment of capillaries are only affected. Comparing to global, there is affection of all the capillaries inside the glomerulus. And in focal, not all glomeruli affected by pathology, but in diffuse, all glomeruli are affected by pathology. So this triggered the podocytopathies. Now come to immune complex deposits. And first starting by membranous nephropathy. Membranous nephropathy is antigen antibody pathology or a pathological type where there is antigen antibody complex or immune complex which comes and accumulates on the basement membrane, principally under the podocyte. So here we call it subepithelial immune complex deposits. These deposits will initiate inflammatory process and lead to release of inflammatory mediators, cytokines, which will lead to injury and damage of the basement membrane and accordingly escape of proteins through the glomerular filtration barrier. So look at this. This is a normal glomerulus with normal capillaries. And compared to this one, where there is membranous nephropathy. Here we can see thickening, diffuse thickening of the basement membrane. This basement membrane, which is very thin in the normal glomerulus, became very thickened in case of membranous nephropathy. But this thickening is not protective thickening. On the other side, it is injurious and it is damaging thickness. And this is how it looks in immunofluorescence. I mentioned previously that one of the three methods of assessment is immunofluorescence. And in immunofluorescence, we can detect certain antigens, antibodies, or immune complex deposits inside the glomeruli, in the glomerular basement membrane, or in the related structures. So in case of membranous nephropathy, we can detect these immune complexes or these antibodies or antibody deposits surrounding or along the surface of basement membrane. And by electron microscopy, look at the normal one on the right side, where there is average thickness of the basement membrane, and compare to the thickness of membrane on the left side, and look at these red arrows. It refers to globular structures inside the membrane. These are the immune complex deposits. In membranous nephropathy, there is diffuse thickening of the basement membrane. When this diffuse thickening is associated with increased number of cells, hypercellularity, or proliferative glomerulonephritis, this is termed membranoproliferative glomerulonephritis. So this term, membranoproliferative, means there is pathology in the membrane which is thickening like membranous, and another pathology which is proliferative, meaning increased cellularity or increasing the proliferation of glomerular cells. So these are the two types of immune complex deposits. Here remains two other types of deposits which are diabetes and amyloidosis. In amyloidosis, there is deposition of abnormal immunoglobulin light chain. And this is not usually confined to the kidney only, but may affect different organs or may cause deposition in several body organs. These immune complex deposits appear as mesangial deposits or mesangial thickening in the microscopic assessment of amyloidosis. And here is a case of diabetic nephropathy, when there is also mesangial expansion forming nodular-like structures, what we call Kymel-Stein-Wilson nodules, which are characteristic of diabetic nephropathy. Now come to the last step of the lecture, last station, which is the treatment of nephrotic syndrome. Treatment of nephrotic syndrome involves either conservative and/or immunosuppression. The conservative line of treatment will be selected to treat the symptoms and the complications of nephrotic syndrome. So antihypertensives will be described to control hypertension, and especially if proteinuria is exceeding 1 gram per day. Antiproteinuric agents, of which ACE and ARBs, ACE inhibitors and ARBs, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers, are the most commonly used antiproteinuric agents. Restriction of salt in diet, use of statin for hyperlipidemia, and use of anticoagulation to prevent the tendency for hypercoagulability or hypercoagulable state, and substitution for the protein losses by nutritive protein supply. Also, immune suppression are considered in case of primary nephrotic syndrome or in case of nephrotic syndrome caused by autoimmune disease. Here we can use a variety or combination of immunosuppressive agents like corticosteroid, cytotoxic agents, calcineurin inhibitors, biological therapy, and others. So the supportive treatment of nephrotic syndrome will include treatment of hypertension, proteinuria, edema by diuretics, and the treatment of metabolic consequences. And the disease-specific therapy will involve treatment of the cause and use of immune suppression. Among antiproteinuric agents, RAS blockers, renin, angiotensin, aldosterone system blockers, is the gold standard therapy or the key therapy to be used as antiproteinuric agent, especially if the patient is hypertensive. To remind you, we have angiotensinogen produced by the liver, which become activated by the renin enzyme released from the kidney into angiotensin 1. This angiotensin 1 is still inactive and needs to be further activated, and this activation will happen through angiotensin converting enzyme into angiotensin 2. Angiotensin 2 will act on two types of receptor, angiotensin 1 and angiotensin 2 receptors. Talking about RAS blockers, this means that blocking renin by using direct renin inhibitors, blocking the angiotensin converting enzyme by use of ACE inhibitors, or preventing the action of angiotensin 2 on its receptors using angiotensin 1 receptor antagonist. These are the classes used for RAS blockers. Otherwise, angiotensin 2 receptor agonist can produce favorable effect. The angiotensin 2 plays an important role in maintaining the intraglomerular pressure. Angiotensin 2 is responsible for vasoconstriction of the efferent arteriole. Just imagine we have an afferent arteriole bringing blood, and we have an exit vessel, which is the efferent arteriole. When we constrict the efferent arteriole by angiotensin 2, the pressure of the glomeruli will increase. When we constrict the exit, the pressure inside the glomerulus will increase. When we use angiotensin 2 blockers, this will lead to vasodilatation of the efferent arteriole. And when there is vasodilatation of the efferent arteriole, this means that the pressure inside the glomerulus will decrease. When the pressure inside the glomerulus decreases, the power, the pressure it exerts to filter more protein also will decrease. And this is what's happened when we use RAS blockers. Management of proteinuria. Proteinuria represents the second decay modifiable factor in patients with glomerular disease. Most studies suggest that proteinuria less than half milligram per day, this is half gram per day, can prevent progressive kidney loss. ACE inhibitors and ARBs reduce the intraglomerular blood pressure, reduce the glomerular hypertension, which can contribute to progressive renal failure. ACE and ARBs in previous trials succeeded to decrease the proteinuria by an average of 40 to 50%, and there is little evidence that ACE inhibitors differ from ARBs in this respect. Management of nephrotic edema principally involves use of loop diuretic. We can use oral loop diuretic like furosemide. If there is no response, double the dose. If not, we can add small dose of oral thiazide, especially if the kidney function is normal. If not, we can now use intravenous bolus of diuretic or add intravenous human albumin. If all this is not giving adequate response, there is the time to do ultrafiltration, which means removal of water from the kidneys through dialysis machine. Take a home message at the end. Normally, the glomeruli is composed of protective barrier, which is a glomerular filtration barrier, and this barrier is formed of multiple layers that prevent against escape of proteins through this barrier. Normally, we have daily protein excretion, but it shouldn't exceed 150 mg per day, and it shouldn't exceed 30 mg per day regarding albumin, and this urinary protein is composed of multiple proteins, 15% of which is albumin. Other proteins are also excreted daily. Proteinuria not necessarily caused by renal disease. It can be caused by renal or extrarenal disease, and sometimes it can be transient in origin, like in cases of cold exposure and vigorous exercise. Pathologically, nephrotic syndrome can result from podocytopathy, like minimally changing disease, or focal segmental glomerulosclerosis. It can result from immune complex deposit, like the membranous or membranoproliferative GM, or other deposits like in diabetes or amyloidosis. Treatment of nephrotic syndrome will rely on either conservative and/or immunosuppression. The conservative lines of treatment, which involve a treatment of hypertension, proteinuria, hyperlipidemia, and thrombosis. This is the symptomatic and treatment of complications. And in case of primary or autoimmune disease, we use other immunosuppressive medications. And wishing you all the best. Thank you.